everybody, and welcome to the first episode of Let's Learn Surgery, yet another initiative of the Facebook group Learning General Surgery being run by Patta Radhakrishna. We hope to involve all students and teachers, both members of Learning General Surgery and otherwise in this program. We hope to do it every week on Tuesdays at 8 p.m. And before we start today,
ma'am, I think you should
sorry,
stop.
I'm having some problem with my audio. Just hang it. Yeah. I'm sorry, I'm having some problems with my internet. So I won't take too much of your time. Over to Radhakrishna to introduce Ilango and how this idea of starting this program happened. Over to you, Radha.
Good evening and welcome to this inaugural session of Let Us Learn Surgery and the initiative of Learning General Surgery. Learning General Surgery is a Facebook platform started about 8 years ago. Myself and Dr. Giridhar Sharma together started this, and over a period of time it has grown in volume to have more than 40,000 members. Vidya, it's your connection which is giving this thing. Over the years, we focused much on the basics of surgery, surgical training, innovation surgery, Indian surgeons, and everything that is good with surgery and allied specialties. And we had many super specialists come in, and actually during the last lockdown we were doing something like 7-8 lectures per day, and many senior professors were involved in it very actively. Then once we started working, then our focus in LGS has come down again. Slowly we are getting into that lean period of the third wave, and it's sort of coinciding with this. And in a casual conversation with Dr. Ilango and Dr. Vidya and a couple of others, we thought that we should focus more on what is right, or what can be right, or what is wrong, or what can be wrong with surgical training in India, because with such so many medical colleges and the number of students increasing tremendously, whether any proper syllabus is followed or not, or how can we improve, and a couple of other things about soft skills in surgery, many areas like surgical audit, how to do rounds, how to document, and mainly how to publish, how to do research. With Dr. Andis brought forth a wonderful book, and with so much energy, and his energy seems to be increasing year by year. And I think with all these things together, we start a new program, weekly program called Let Us Learn Surgery, and involve all the stalwarts and students in this particular endeavor, and to take this program forward. Dr. Ilango, I thought, is the right person who's got so many new ideas in surgical training, and then to keep us all together and active with Dr. Vidya, who's the chief anesthetist at Mother Hospitals, Chennai, who will be threading and who will be in contact with all the faculty. Dr. Ilango Sethu has done his MBBS from Mother Medical College, MS from Trivandrum Medical College, MCH Gastro from Madras Medical College. Subsequently had a 2-year training in liver transplant in Pittsburgh. Now he's back as one of the senior transplant surgeons in Mayot Hospitals, Chennai. And our wonderful faculty involved, Dr. Rajgopal Shana, you all know, is a professor and head of surgery, Manipal, KMC Manipal. Then Dr. C.R. Ballal, who was the senior and professor of surgery for a long time at Kasturba Medical College, Mangalore. And we have Professor Ananthakrishnan, you all know, that is one of the senior professors of surgery and has been heading Department of Surgery, JIPMO, for long years, and is one of the well-known academicians. Then We also have Professor Giriraj Sharma, who's one of the backbones of learning surgery. And to top it all, we have Professor Samran Nandi, who's a father of a modern GI surgery, ethical surgery, academic surgery, and whatnot. And he needs no introduction. Over to Ilango.
Thank you, sir. Thank you. Thank you to all the team members in Learning General Surgery, particularly to Dr. Patta and Dr. GDS. Professor GDS, they together formed this group helping out youngsters to rise up and become good surgeons. And they accepted us to be a part of the bandwagon, and we've gone through these long years, and it has been a wonderful experience. Now, when this program was envisioned, it was to help all the youngsters, and we dedicated more of our time to helping them out. Now, after 8 years, it has grown to a 40,000 membership, and it's still increasing day by day. And the content has proved useful. But over these years, we have also learned a lot of lessons of how difficult it is to engage students. So just to touch upon what he said, we discussed about how we can improve teaching among students and how they can learn. And I was fortunate to give one of the lectures in Marvelous Medicine hosted by Dr. Vidya on surgical pedagogy, the gaps and knowledge in surgical teaching. So that brought forth this idea. As my title slide, I have put the whole series topic as Let Us Learn General Surgery, and it's not a single person event. So the whole learning general surgery team has to be involved to bring forth new ideas as to help out our youngsters and the future surgeons. Now, I have put together the photographs of some of the best teachers I've ever known. Right at the left-hand top, you have William Osler, whose quotes we read every day. Such a enormous personality who brought forth, even though he was a physician, as a surgeon, I still love reading every one of his works, and the way he brought forth medicine as a modern specialty in the US. We have Hamilton Bailey and Professor McNeil Love, whose book was much favored during our younger days, even now. Just below him is Professor Dave Sebastian. It's his book. It is learning with him is called A Decade with Dave. He was a very strict disciplinarian, and I think he starts his work around 4 a.m. or 5 a.m. in the morning, and then he's a cardiothoracic surgeon by training, and he trained numerous surgeons across US and another well-known surgeon. A lot of people think of Starzl as the man who actually brought forth liver transplantation, but another dimension in him is Starzl trained every one of the surgeons in the world. There was a link to Starzl in one way or the other. And he, when I was there in Pittsburgh, he was near his 90s, and he still used to come for the biomedical research wing and help out youngsters who were then doing belatacept, the co-stimulation blockade pathway, and he was actively involved in that research. So he's such a great teacher. Obviously, the big picture is Professor Halstead, the man who was responsible for the Halstedian system of training in surgery in the US. But right below, you find a small picture of a statue of a man. He's Rip Van Winkle, the man who slept for 20 years and woke up in a different time in a different world, completely blissfully unaware. One of the quotations that I love to read from the Oxford textbook of medicine, the old one, the huge big dinosaur we used to carry, the one which replaced Price textbook of medicine, is to say that there can be no medical Rip Van Winkles. Every one of us continues to learn throughout our lifetime in order to keep ourselves abreast with the newer developments, and it is right now, it is impossible to keep up with all the developments in all the medical specialties. I'm actually fortunate to stick to a small area in the abdomen, and I still find it difficult to keep abreast with the modern developments and the molecular biology that brings in new change in our field. Am I clear? Yeah. So I asked these basic questions. My job today is very simple. I'm introducing the topic, and I want to keep this series. I want to open a lot of questions and to get suggestions from the teachers and the eminent personalities here. So I raised these basic questions. How does one become a surgeon? And that led on to the question, which is like a dark cloud. How does actually one become a doctor? So to do this, I simplified what I did. So there are three aspects that one does to become a doctor. Is to accumulate a knowledge base, facts, some paths about and algorithms, and a purpose, the end point of the care. So all those constitute a body of knowledge that is to be acquired. The bundle, the size of the bundle varies with the level of training that you require. The second one is an aptitude, which is probably an inbuilt gift, or an attitude, which is a mental state with regard to a fact or a position. A good to problem solving is one of the key ingredients of becoming a good doctor. And lastly, I have put a vague idea to serve. It's very hard to get the millennials to understand this, but at the time when I started my MBBS training, the idea to serve a people, to care for their bodies, was still an eminent principle. I think it still is true, but not of value in the current world scenario anymore. And the millennials simply don't understand it. So I have put it as a vague idea to serve. So these three things are very essential for one to become a doctor. A provocative book by Robert Persig, or Zen and the Art of Motorcycle Maintenance. The last phase of the book shows how Phaedrus and his son are sitting on the motorbike, and they see the same blackbird, which the author saw in the first travel, and his son sees the blackbird and yells at him, and then reminds him of the beauty of the place. Whereas in the first instance, the son never saw the blackbird, never understood its meaning, and never felt joyous to be interested in the blackbird. So every one of our students will start with some amount of disinterest, but as they go, we must be able to transfer our interest and our knowledge to personality, so that they can become the doctor we see in them. So the knowledge base in medicine is actually changing, and it's constantly evolving. So at present, we have YouTube, we have UpToDate, we have the American College of Surgeons putting up a lot of things. I've just quoted a few. The SSAT has its own journals, websites are good, ASLD has its own courses, journals, ESIL has the same. So information, knowledge is always available, but it's available only as information. So we need a skill nowadays to learn how to learn and crack the knowledge base. So to simplify, I have put together something like this. These are the transformation levels in training. So the simplest way to remember this is Wiki. Wiki W stands for wisdom, I is for intelligence, K is for knowledge, and I is for information. So we'll start from I. The medical student has a body of information. In fact, it is said that the medical training is one body of knowledge where you have to memorize a lot of factual information. So the medical student essentially is given a bundle of information about which he has no correlation. All what we ask them is to repeat the information back to us for them to be qualified as a good medical student. So that information, when he becomes a surgical resident, requires a correlation. He needs to identify that an alkalosis is a contraction alkalosis, and acidosis can be bowel ischemia, things like that. He needs to correlate. The correlation of facts is the actual knowledge, and it gradually increases with time and probably maturity and seniority. So the knowledge base keeps on expanding as you correlate more and more of the known information into structured algorithms. What happens when you become senior is when you apply the well-correlated algorithms in new situations. So application in absolutely new situations is what makes you a good consultant. I also add that to be an expert consultant, one needs to manage his complications very well. It is not essential that you do the primary surgery or the primary treatment very well. You should also know to manage the complications of another person so that you know the gaps in the algorithm very well and you know the entire flow of the algorithm. And you must be able to do a cross treatment across new situations. You must be able to apply your current knowledge. That is what makes you a consultant level practitioner. To be a teacher is something that requires a different level. You need to see far and you need to see before. That's a leadership skill. And I think in medicine, it is an essential teacher skill. Wisdom also implies that you know where the algorithm is not of value. If you know that, that actually gives you an edge and you can keep your trainees in the right pathway where they can learn appropriate things and be warned about dangers in that algorithm. So this is just putting together these things. Obviously, in a large room full of knowledge, you need to find out the right doors. And that is helped by algorithms. And like a small key, a key skill, and the key ability to learn new things can help you open many doors. The ability to learn new things has become mandatory in our profession in the current scenario. This is where I believe that the younger generation is always confused. They have their information on fingertips through Google, on their mobile phone, sometimes with up-to-date. They've got phenomenal resources. So today I gave an ABG to my junior doctor to read. And as I was talking to the patient, she came back and said, it's a mild metabolic acidosis, hypochloremia and stuff like that. I said, that's good. And she said, no, I just read it out of the mobile phone. So they have an app for everything. So, but what to do with the information is something we have to teach them. And that is the challenge we face. Now, when I thought about this, so I looked at things like this. How do you provide information? These challenges still remain. So in the last 3 or 4 months, I have tried multiple ways of doing it. I created a sub page in Facebook, teaching them about small things like which they require for entrance examination. So I provided them with 250 questions. So thinking that they are not interested in the videos which we provide, and most of the younger doctors were interested in getting learning about MCQs to pass the NEET examination. And still, after 250 questions, the engagement was hardly about 8 to 10%. So I kept a close watch, provided them with diagrams, explanation, everything. The engagement was very, very difficult. So at least I learned that it's very hard to provide even distilled information to them. And we have to learn how to provide the information. So I'm looking to whether a mobile phone app will help them, or are there any websites which give them even distilled knowledge that will be useful at the bedside. It's still a huge gap in that area. Access is extremely limited. We talked about Sci-Hub in Marvelous Medicine some time ago, which gave a lot of free articles, but I think it's now getting restricted. I also used to subscribe a lot of journals, and I found out that the money is a restrictive factor. It's unbelievable when you talk with some of the medical students, what kind of suffering they go through actually to learn those skills. and with no access to good information, just simple journals. I used to remember a time when I used to go to Professor Rangabasham's house to get and read the latest British Journal of Surgery. And I could subscribe it for 1 year. And I used to get some bits from Dr. H. Ramesh. He would share his access and give me the articles of need. And there were times it is very difficult. I still love to read the American Journal of Surgery. And the time I spent in Pittsburgh, I loved, because the university provided access to almost every journal. That is still a dream in India. So how to provide access is another question. The third one is how to improve skills. We talked about simulation training. We talked about graded responsibility during surgery, teaching them the basics, a lot of things. Patara Radhakrishna ran a lap cholecystectomy course a couple of times. These are very difficult to actually, the skill transfer is very difficult to do. So these are some, we also ran some operative surgery courses on Learning General Surgery platform. But even though people talk about it, whenever we meet in person, we really do not know whether we were able to do the actual skill transfer to those individual students. Lastly, I believe that leadership in the future should include both character and competence. If we focus on competence, we will make the same mistakes what the West did. And if we focus too much on the character, we probably will never develop competence like how we have reached out in India. So we have to teach of the training, leadership, the character, as well as the competence. Now, what I believe is people, youngsters, do not feel confident to be a surgeon at the end of the training. Like when I finished my MS, by the time I was my final year, I used to operate most of the emergencies independently. I used to cover all the problems that happened for my assistant professors. And if they had a rule that if there is any problem in the theater, I'd be sleeping in the post-operative ward, the room adjacent to post-operative ward. They would call me. And if I called them, they would come down to help us out. So, but now when I see the youngsters, they have finished surgery and they still remain like residents for 3 to 5 years, even after they have finished their post-graduation. And I always tell them, surgery is not just the art of knowing. It is the art of being a surgeon. It must come within yourself. And I don't know how to make them understand that. The new problem, I mean, what I wanted to talk about was about character was the Chinese surgeons are extremely good in operating. But this came, I was just looking at star cell transplant alumni a couple of hours ago, and this turned up. The nightmare of human organ transplant harvesting in China, which is still going on, it seems, in 2019, but now it's very difficult to prove unless you actually go and experience that. So this was written in 2019 and was shared in Star Cell Alumni, and it says transplants far outnumber official donors. So you have skill, you have competence, but the character is the most difficult thing to do. To write a paper based on falsified data is still happening so much, even in well-established journals. So it's very hard to find that out when it comes from a good journal. So one must keep their eyes open. And I believe that instilling character is one of the most important jobs of a teacher. Obviously, the millennials are the ones whom we are trying to train now. So this came in the Journal of Thoracic and Cardiovascular Surgery in 2019. How do you attract these millennials? So to use technology, you have to be learner specific. You have to build new team dynamics. You have to really go down to their level. And also, every program should support the teachers. So Learning General Surgery probably can hit the first two, but probably the individual teams must decide about the latter two parts of the training. Millennials are really difficult to do. Now, what we have brought together is a platform. Every Tuesday on LGS, we are going to discuss some aspects of training to make better surgeons for the future. It will be either a lecture or a debate or a discussion for over an hour. What I envision was that it should be like TED Talks, ideas that are really worth spreading. I mean, we have to breed new ideas, even if some of them are wrong, because change is the only constant we are facing But change is extremely difficult and dangerous, whatever level of practice you're doing. What we have learned is, you cannot bring about change by reading books. One of my favorite ones is HBR's On Change Management. When I took up leadership responsibilities for transplant programs, it's very difficult to bring about change in any program. Change involves facing our own fears. I've seen the more senior we grow, our fears actually become monstrous, and we rarely change. That's one of the reasons why we find a lot of senior surgeons resistant to change. And without bringing about a change, we cannot educate the next generation of doctors. Change also involves facing our own failures and addressing the gaps in our knowledge and the gaps in the way we have taught and built up society in the past. And only when you own up our own failures will we face the future in a better sense. There was a small argument with one of our senior GI surgeons today morning and over coffee. And the senior professor of GI surgery, he said, surgical oncology is actually a better surgical training. Well, I said, why do you say that? And he said, you don't know anything about medical oncology. You do not know anything about chemotherapy or any other drugs. And I said, I was surprised. If he had felt that learning about chemotherapy is important for a GI surgeon, he was the professor. He already could have changed the curriculum. So that opportunity to change affects a lot of youngsters and young generation. If you think there is a knowledge that youngsters would benefit, this is a program where you can boldly come and share. And we'd be so happy to receive every new idea. So our question still remains, can we teach our young to know the change, to be the change, and do the change, so that we can make training in surgery a much better thing? As of today, we have 418 videos in Learning General Surgery, and we have 15.1 thousand subscribers in the YouTube channel. But we really don't know how many of them videos were watched by youngsters. When we interact with surgeons in the middle age, they have watched all the videos. They've watched the technical videos as well as the lectures, but we are still not able to attract the millennials. They are a completely different breed. This is something which I took from my surgical teaching. Is another question we have raised is that premeditation is something we have to teach. So I have put learning opportunities as standard, alternate, critical times, no-go situations. The standard situation in one in which you know about a defined disease pattern, you have a recognized treatment, and you have a good day at the office. So an alternative is person within the disease defined disease pattern. There's a subtle special situation. Don't just take it for surgery, for anything. There's a subtle special situation, and still you have a good day. You are still with your wits. Critical times are those in which you have bad situations and bad days. Anything can go wrong on that day. And a no-go situation is one which it's impossible to correct. Once in a while, each one of us is going to face this problem. As youngsters, as teachers, we should inform our youngsters what is impossible to correct as well. I think we can talk about this. And scaling up teaching, we have a large platform with close to 40,000 members. And this is really scaled up. But the spacing effect, the context change, the desirable difficulties cannot be created in a virtual program like this. It has to be done at the local training program. So those are things we have to do that. And we should remember that it's not an adventure until something goes wrong. Only when something goes wrong, it really tests your algorithm whether it is right. As long as everything goes well, everybody thinks what we're doing is right. Only when things go wrong, really understand the need to change. Dr. H. Ramesh used to teach me, how good are you on your bad day? So expertise, when we develop expertise, I see it as knowledge You have to study and think about that knowledge and create new knowledge. And that exactly is expertise. There's one more thing which I teach surgeons in that an expert is one who manages his complication as well as the complications of his colleagues. So I think, yeah, let's skip that point. So for a teacher, you have to be a good student. Like Luke Skywalker, you pass what you have learned. And even when you're the last Jedi, you still have to transfer that knowledge and skill to someone else. And that self-actualization comes before that, before the teacher's calling. The teacher probably is beyond the Maslow's hierarchy of needs. And I leave this as a blank slate. We are open to all ideas. Our first speaker is actually Professor Balasubramanian from Bangalore, St. John's, and he has looked into different ways of teaching anatomy. So that's the first one, which will be held next week. So I leave this with a blank slate on which all of us can put together our efforts to make a colorful palette. Thank you. Thank you, Pata sir. And thank you, Vidya ma'am.
Thanks for that introduction, Ilango. Like Radhakrishna said, we have very senior teachers whom we hope to hear from today so that we can plan the future episodes. We have already put a plan in place for a few episodes, but Professor Ballal, we'd like to hear from you, sir.
Vidya, can we move on before Balal comes back?
Good evening, Dr. Ananthakrishnan. Thank you so much for joining us despite your busy schedule. We'd like to hear some pointers from you, sir, as to how to take this program forward.
Sir, AK sir, you are muted as well. You have to unmute.
Yeah, I have unmuted myself. Nice to be here and share these platform with all of you and some of my very old friends. I see Purnendu here. For a moment, I saw Bala also here, but I don't see. Vidya is here. Pata is there. People who I'm known for decades. And I think the idea itself is very worth pursuing because surgical teaching at best of times is challenging. And now in COVID times, it is near impossible. And I particularly feel very sorry for the 2 successive years of postgraduates who have graduated in the last 2 years and underbaked, so to say. Everybody passes the exams, but they have gone out into circulation without the skills or the knowledge or the attitudes that is required to be a practicing surgeon. The other fact which I agree with Ilango is that even at the completion of the course, in best of places, they feel inadequate. I have not seen a single postgraduate in the last so many years who is competent and confident enough to say, tomorrow I am going to be on my own. Either they're looking for attachments to some places or looking for another opportunity to add to their knowledge by pursuing higher specialties or doing a fellowship here and there and just moving from place to place till circumstances dictate that they no longer can move around and they have to settle somewhere. Finding people like Purnendu is rare because the moment he left my unit, he started center at Calcutta and now he is a big name in the eastern part of the country. There are many challenges and both in developing the manipulative skills for which surgery is known, but also the soft skills, the ethics and the professionalism, which is very, very difficult these days to be confident that you will find it everywhere. Training in those aspects, particularly communication, and that's why we have so many episodes of dissatisfaction by patients and their relatives with the outcome of surgical procedures, largely because of communication issues. And they don't realize that that is what is going to be much more important in attracting a clientele and keeping them with you rather than pure physical skills. And unfortunately, the curriculum does not find time for these things. It is left to the individual to grasp what he can, and no deliberate attempts are made either by the teachers or the students to develop some of these soft skills which are absolutely important. The third thing that I have found recently in my life after I left JIPMER is motivation levels amongst the students are not as high as you would expect those who are paying 40, 50, 60 lakhs annual fees and who come and join private institutions to get an MS in surgery. Now, I don't understand that. Having spent so much money, one would expect that you would be much more inclined to learn. But somehow, the students who are paying 450 rupees in JIPMER were far more motivated than those who are paying 45 lakhs in the college where I work. So that is something that you have to start even before the curriculum starts to get them online and get them to understand what they are there for and how their journey in future life is going to be influenced by those very short 3-year period. Because later on they'll be largely on their own. They will not be in a protected environment where mistakes can be made and somebody else will take the blame for it. So that is the second issue that we have to focus on. Otherwise, teaching them surgery is becoming rather mechanical in these COVID days. And the fourth thing which Ilango must be aware and all of you must be aware is the expansion of knowledge in medicine. I read a paper by a social scientist called Janssen some time ago who estimated the doubling time of knowledge in medicine. He said in 1950, the doubling time of medical knowledge was 30 years, which means you can graduate, you can postgraduate, you can finish your service, and the medicine that you learned in your medical college is still valid. That was in 1950. In 1980, it was reduced in 30 years' time, it was reduced to 7 years. That is, soon after you graduate, finish your internship, finish your post graduation, the knowledge in surgery has doubled, and you have to learn a whole lot of new things. In 2010, 30 years further down the line, the doubling time came down to 3.5 years. That means even halfway through your MBBS course, you have to relearn things that you learned in the first and the second years because knowledge has changed. And I was amazed when Janssen said in 2020, the doubling time of medical knowledge is 73 days, 2.5 months. So 5 times in a year, the knowledge has doubled. And you can understand keeping up with it means sourcing information, understanding the relevance of the information that you source, not just accept it as it is, argue the rationality of what you have sourced, knowing when to apply it, and more important, when not to apply it, and then seeing after application whether you should want to apply it again in future, because everything that you source is not necessarily going to be successful in your own practice. These are very discriminating decisions one has to make constantly. And these are the things that we have to struggle with as teachers because information is at a fingertip. In my days, when I passed MS in 1973, Dr. Nandi joined immediately after that. And there was no internet. You had to source by going to the library and read the journals, or you had to source from the books, one of which was Bailey and Love and Sabiston and Schwartz and so on and so forth. Now information is available at your fingertips. Anybody can enter 3 words in Google and get 20,000 hits and papers. So sourcing information is not important. And that's what I always used to teach my students. I don't know whether they remember it still. When knowing when to operate is not important. Knowing when not to operate is much, much more important. And I hope they remember those lessons when they have gone out after the qualification. So there's a lot that we can do. I think the platform is very good. And we may be able to fill in some of the gaps with the curricular training of surgery, because some of these issues are not covered in the curriculum at all. And if you see, the regulatory agencies are hardly looking at the curriculum. The last postgraduate regulations came in 2000. The next came in 2020, after 20 years, which for them, for 20 years, the curriculum was frozen in all the subjects. And therefore, they have very little time to devote to soft skills, to attitudes, to professionalism, to ethics, to decision making, to leadership, working in a team, communication, and every skill, which is probably as important as putting sutures or dividing tissues. So I think we'll like to see how the platform goes. And there are many things that we can cover, and I'm looking forward to being part of the group and learning and contributing what I can. Thank you very much, Pata and Vidya, for asking me here. Thank you, Ilango, and I hope that we all benefit mutually from each other during the next few episodes or whatever length it is going to run. And very glad to see Dr. Balal, whom I am seeing after a long time, Rajgopal, whom I'm seeing on webinars, and Dr. Samiran, of course, from the good old All India Institute days. Thank you all very much.
Thank you so much, Dr. Ananthakrishnan. We have actually decided that one episode every month will be devoted to soft skills and teaching of soft skills, because we understood that that's probably something we can do better than bedside teaching. So, Professor Balal, we'd like to hear from you now, sir.
Yes, please. Can you hear me?
Yes, sir. Loud and clear.
Right. Now, at the outset, I should congratulate Dr. Ilango for the wonderful exposition he's done for the last 20 minutes. He has covered a very broad spectrum. I want to start right at the beginning. I'm sure Dr. Ananthakrishnan was original JIPMER. He used to see the cream of the Indian medical students coming up, and then the postgraduates. What is happening today is general surgery is not the first choice for most of the undergraduate students. Question is asked, what is general? They have gone to the extent of asking, what is general surgery? Way back in 1981, I think somebody says residual surgery. My own colleagues are complaining. They are general surgeons. They see a patient carcinoma of the stomach, they go to PATA. They see a patient with carcinoma, the renal carcinoma, they go to urologist. What is left? So as finally a student, the choice at our time used to be surgery. I'm sure Dr. Ananthakrishnan would agree with me. Surgery was the first choice for most of the toppers in the class. It is no longer true. So we are left with, because the main complaint Ilango has is that the attitude of the student seems to be much less compared to the enthusiasm of the teachers. To my mind, one of the reasons is that the quality of students who are getting into surgery is not as good as it was some decades ago. It is a gradual change. They feel that after doing MS, they have to do MCH. After MCH, they'll get into teaching jobs are becoming less than corporate hospitals, or they can't move into a smaller place. So there are a lot of problems these boys feel. Unlike radiology or dermatology, which are now most prominent choices. So we have to look at the pool of students we're getting who are not as good as they were, say, about 2 to 3 decades ago. This change is bound to happen. It's happening more rapidly. The second thing I want to emphasize is that all the time we are putting the blame on the students. I think a lot of blame should be put on the teachers. Is there a way to communicate with the teachers? As I was a lion for a long time, and there's a special program, Train the Trainers. So can we have a program which is meant for the young teachers? There are, thanks to a large population, we have a good number of really enthusiastic young teachers who want to teach well, learn. So to segregate them, to identify them and get them going is a job is extremely difficult, but Patta is a genius. And Dr. Sharma, of course, is beyond compare. So try to get these young teachers who are keen to learn. get them into LGS, and through them, if you get to the student, because I think whatever said, as has been said, repeatedly said, online, it looks nice when I talk, but how much is absorbed, how much is remembered. And as said earlier, the old system, when I was a postgraduate student, most of the open surgery, chief used to come at every step, look at me. And as Patta said, half the time when we were postgraduates, the teachers were sitting in the surgeon's room. Most of them are smokers at that time, of course. And we used to operate. Those days are gone forever. So my request is identify the young teachers, get them to learn, so there'll be direct contact with those teachers and the students. And that's the way I feel the way forward for LGS. You're doing a wonderful job. Happy New Year to everyone, especially Dr. Antakrishna. I'm seeing a long time now. And Happy New Year. And God bless LGS. Thank you.
Thank you so much for your kind words, Professor Balal. We actually wanted to have this session mainly because we want to get students also to tell us what they actually would like to be taught. And of course, seniors like you who will be there to guide us, and the younger teachers, what they feel is holding them back. So thank you for bringing up that point, and that's what we hope to do.
And I add one more sentence. I'm reminded, Dr. Antakrishna was talking, today what's happened, with due apologies to, this is not personalized, but applies to a large number of private institutions. When a student pays 2 crores to get an MSc, he feels that he should pass the exam. They spend so much of money. He feels that the duty of the college is to give him an MS degree. And that's why at the end of MS, they're absolutely nowhere confident to do any of the, I still remember my MS exam more often than not, operative surgery, I used to start with circumcision. They want to start with radical mastectomy, I would start with circumcision. They come to that stage now. They're not confident because for the amount of money they've paid, they think in return, they should get an MS degree. And their feeling is we can go and get trained later on. It's a very unfortunate development, but we have to face these facts. Okay, thank you, madam.
Nowadays, Vidya,
Yes,
you
sir.
have to try it very, 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 very hard in order to fail in the exams. Unless you want.
Krishna, what will happen is they'll remove you from the examiner's list. It happened to me.
No, I'm telling you that is the situation.
In this
The
very
examiners work much harder than the candidates sometimes.
No. I was told in this very city that if you continue to give results like this, we will not call you. I said, thank you very much. Because we depend upon prior practice. Our college salary was absolutely nothing. And I was told, specifically I was told, if you give this kind of results, this university will not call you. I said, thank you very much. Okay, the very unpleasant side of the situation. Yeah, Vidya can go ahead.
Exam is only one thing. Passing exam is not the ultimate. It is the adequacy of training that we have to ensure. Passing it, if not the first time, second, third, they will pass sometime. Nobody is going to discontinue and go away.
No,
but to ensure that it happens during that period is the most difficult part. And one thing that nobody has mentioned so far is the number of candidates. When I was in JIPMER, when I joined JIPMER, we had 4 postgraduates in surgery, one in each unit and one extra unit, person in the first unit. Nowadays, they have 25 students, and the Lalok Theatre, where we used to have classes, has 75 students sitting there because there are 3 batches of thing. In our college, we have 16 postgraduates admitted every year. So regulatory processes also become very lax and not related to the facilities available for various reasons. You know the reasons and I know the reasons, and we don't have to go into it. But that is what we have to face. The same type of clinical material, the same quantum of clinical material, the same number of teachers, almost the same, but 3 times the number of students, 4 times the number of students. So even apprenticeship is difficult.
Perhaps, Ilango, we should have some episodes on how students should be actually examined down the line during the series.
Sure.
Now I'd like to welcome Professor Kapoor. Sir, would you turn on your video and unmute yourself? Thank you for joining us, sir.
Good evening.
Oh, Vinay, welcome.
And before you start, sir, it's a proud privilege to introduce Professor Kapoor. Is a born academician. I think every single minute of his awake hours, he'll be thinking of teaching someone, writing something for students, and taking care of them. And he's totally dedicated. He's presently the chief of GI surgery at MGM Medical College, Jaipur, and I had a pleasure of visiting him recently, and respect the institute has for him. Professor Kapoor.
Thank you, Pata. Good evening, Dr. Anantkrishnan. Good evening. Good to see you. Just some stray thoughts. I didn't know that I have to say something because I thought I'm just invited to attend. But as the discussion was going on, Dr. Ilango said that before you become a surgeon, you should be a doctor. I'll even put a word before that, that you have to be a good human being also. Somehow this is probably generation gap. Our parents used to say the same thing for us, and we say the same things to the next generation. That the social values, whether in society, whether in institutions, whether in workplace, probably are changing. I feel not for the better, but for the worse, whatever the reasons. As parents, as teachers, it is our duty and responsibility that we try as much as possible to inculcate good values in our children as well as students, whom I always consider as my professional children. I mean, we all have biological children and we have many more professional children. Unfortunately, even at SGPGI, where I served for more than 3 decades, I started having a feel that of late, probably, I hope I'm wrong, some students join only to get the degree. They do not come with the intention of getting trained, getting educated, or getting better. They want that degree so that they can go out in the marketplace and be a super specialist and make a living kind of thing. So the profession gradually is turning into a job which gives you money. I mean, I have nothing against money. Everyone wants, everyone should get money because money gives you so many things. But I think that should not be the primary aim. And unfortunately, sometimes I feel that is that what is happening? I don't know whether we can do anything about it. Other is that I remember when I have not been taught and trained by Dr. Anantkrishnan, but I have been taught and trained by one of his immediate younger colleague, Dr. Chattopadhyay. And I remember how eager we were and how kind of competitive with each other we were as residents, that we would like to present a case during the ward rounds to Dr. Chattopadhyay so that he can teach and train us. That kind of race was there amongst all the contemporary residents. Today, I find that lacking. Following on Dr. Patta's footsteps, I also started an online portal, the Jaipur Surgical Tutorial, mainly for the students in Rajasthan, but a lot of other students and teachers also have joined. And when I tell them that prepare a case, prepare an operative procedure, or even ask questions, they are not forthcoming. This is when we are fortunate to have gathered faculty from all over the country to spare their 1 hour on a Saturday morning, 9 to 10, when they are busy with other activities, to teach them. People like Dr. Piyush Sani, Puneet Dhar, Indian, and so many others, Dr. Kate, and so many others. So I don't know whether it is their hesitation, whether it is they have got used to spoon feeding. They just want to listen. They don't want to listen. They don't want to ask. So that is another thing which I feel we need to change. There is a change in the teacher-student relationship also from the days I won't name, but there were teachers of whom we, the students, were scared, even afraid. We wouldn't want to face them either in the clinics or exam, because they were kind of little overwhelming. And then came a phase when we had very good relations. The time when I trained, and some of my initial trainees, who as soon as they passed, they became good friends and good family relations. Even now, strong family bonds are there. But then a phase came when we started distancing, partly because I was not spending much time with them, and partly because of their change in attitude and perception. As I said, they just came for getting the qualification. Also, I feel that I won't say all, but a significant number of students have probably started taking this relationship in a very casual manner. That earlier feeling which we used to have towards our teachers and trainers, sometimes I find it missing, which is little discouraging. As far as the training programs are concerned, I mean, except for, I can say maybe 20 or maximum 30, 40, 50 good institutions, majority in the government sector and some in the private sector. The less is said about remaining institutions, the better. Somehow their spectrum, their volume, their quality, both in terms of patient care and teaching, leaves much to be desired. I think our statutory bodies and even our professional societies have kind of failed in our duty and responsibility to keep a check on this. And this recent policy of the government that every district will have a medical college, I don't know where they are going to get teachers from, unless there is a drastic change in the way we treat our teachers in medical institutions. So there are problems, but in spite of that, I think that most of us continue to do our job as a teacher as best as we can. But I'm sure there is a change as compared to what used to happen 30, 40 years. I can at least talk of 40 years now, since I was a resident in the early 80s. So these are some stray thoughts. I would be very happy to contribute to any of the programs in whichever way I can. I suppose what I can understand that this forum will kind of cover non-surgical topics. So I will think of one or two topics and send the suggestion to Dr. Bhatta and Dr. Ilango. Thank you very much.
Thank you, Dr. Kapoor. Like Dr. Ilango Sethu said in the beginning, the challenge is going to be in engaging the millennials. That would be the first step. So we want this forum to be open to all students, teachers, and would-be teachers. So I'd like to hear from Dr. Haripriya, who's a trainee. Dr. Haripriya, can you please turn on your video and mic?
Yes, ma'am. Good evening, ma'am. Can you hear me, ma'am?
Yes.
Yeah. Good evening to everyone. Good evening to all the eminent professors present here. Being a surgical trainee in this COVID era, I'm doing my third year general surgery actually. So it has lot of changes from being an intern, being exposed to surgery, and being a postgraduate in this era, being exposed to surgery. And especially in this COVID times, there's very less intensity of cases, which we happen to see. It's not just the cutting chances, ma'am, but it's about seeing the variety of patients has come down. But LGS Forum has given us a lot of opportunity in learning as well as to know things. So where there are very few complications which we don't even see, which is being discussed in the forum, which is very helpful for us to proceed further. And we are very happy with all the discussions that is taking place now. But in pertaining to the trainees, I have only one thought, ma'am. Like, there are two kinds of trainees. One person who takes up surgery by chance, and the other person who takes up surgery by choice. So the person who takes up surgery by choice, like if they wanted to take surgery and they take surgery, they are the ones who get not get fulfilled with whatever is happening in this era. because of this COVID times or whatever it is. We lack by academics as well as skills. So I guess if it will be helpful if teachers help us in improving and enhancing those skills. And that's all from my side, ma'am.
So Haripriya, you had 1 year of non-COVID time training, right? So
Yes,
let's take that as the reference. What would you like to see different, and how would you like the teaching and training to be different from what it is? I mean, unfortunate, but these 2 COVID years, of course, things have not been normal at all. So you have seen
Yes,
1
ma'am.
year of so-called normal training. So
Yes,
what
ma'am.
would you like to be discussed in future episodes of Let's Learn Surgery about teaching learning methods? A sentence or two, please.
Ma'am, the discussions of complications. There are very less. We normally discuss cases, ma'am, but discussing the complications on how to manage a complication. For example, we see a duodenal stump blowout. There was one of two cases which I have seen in my normal period. After which there are very less patients who come to get operated. So we would like the complications on how we manage the complications. The small things like nutrition, on how managing the nutrition of a patient, post-operative care, that all will be nice, ma'am, if we discuss.
Right, thank you. Thank you, Haripriya, for sharing your thoughts. Professor Shenoy, sorry for keeping you waiting. I just wanted to get the students' perspective in because so many teachers had spoken. Over to you, sir.
Yeah, thank you. Thank you, Dr. Pata. Sir, Anantakrishnan sir, namaskar, and my guru, Professor C.R. Balal, every one of you, senior members, faculties, and all Prakash has joined from also from Tirupati, etc. Several things have been told in this forum that regulatory body, it is not in our hands about the student selection, number one. It mainly lies in three things, basically: student, as she has told, interested or not interested. Second important is the person. Person is we means teachers. And last but not the hospital. What is happening here is whether COVID or no COVID, there are so many places the volume is not there. Hospital volume is not there. About 700 plus medical colleges now with so many seats which are enhanced, etc., etc. I have gone as examiner to find hardly any patients, and number of PGs are also increased. So what LGS can contribute, because otherwise it's all same thing. I'll be repeating what all our gurus have already told now. What I believe LGS can do is, like she has pointed out few things. When I'm a little younger means not truly young, but compared to my gurus who are here. So today the discussion of MS-PG does not end at the diagnosis, and nobody will fail because of the diagnosis which is wrong. Rather, if you don't interpret CT scan, ultrasound, endoscopy, it will be taken seriously. Quite contradictory to what probably was there 20 years back, or when, of course, when I was a PG, there was endoscope and ultrasound CT was not there. So what I'm trying to tell, an important point here is, let there be a more stress from LGS should focus more on these issues related to the cases, whether it's a stomach you are discussing, or whether you are discussing liver, whether you are discussing hernia or something like that. Is point number one. Point number two, she has pointed out an important point about the complications or something. So what I will put it in a nice way as a post-operative ward. Actually, it is a DePenby, they have a model, no, where there's what's called as a other ward rounds. Nothing but ward rounds. That is how it is. So there used to be something called as a grand ward rounds. You know, when I was a UG undergraduate also, PG also. So that is also another thing which is missing. So let us, I'm not trying to blame anyone here, student or teacher or hospital. What I'm only telling LGS can do is, in this manner, focus quickly on the clinical related issues, and then on the investigations, then on comes to the skills which they are missing. That's what they told. Maybe an abscess drainage also they would have missed now. So lots of faculty who are associated with this can make up a small videos of all small procedures. Actually speaking, everyone has a mobile camera and other things, high quality definition. So skill enhancement can, at least they can have a look at it. I hope those basic skills plus some post-operative ward rounds. She said no complications. So whether it's a post-operative fever or a bile leak or whatever commonly done, and a little bit of this imaging, etc. That should do. These are my quick thoughts at this stage. Thank you. Thank you for the opportunity.
Thank you so much, Dr. Shanoy. Along with Professor Ananthakrishnan, Pattarada Krishna and I are very happy to have yet another teacher of ours, Professor Rajaram, who's logged into this meeting. Professor Rajaram, we are trying to start a new program on how to teach surgery. Your input, sir. You're muted, sir. You need to unmute yourself.
Thank you very much, Vidya and other friends. And I'm so happy to see some of the old faces, including Anant. Anant Krishnan and myself, we were working together. What I thought was, it's a beautiful step that you have taken, Vidya, about this forum. But what I personally feel is that instead of restricting ourselves to the general surgery, maybe that we can expand this to principles of training and of surgery. That would be nice, so that you can involve other specialties like gynecology. I'm a gynecologist. I became a gynecologist not by choice, but by chance. But although I took that one, but I utilized to use the principles of and practice of medicine that I gained from all over the world, especially from Vienna. For example, in Vienna, the training is given whenever the surgeon makes a mistake. He goes immediately that afternoon to the dissection hall and dissects that particular part to see where he has gone wrong, so that he can prevent that. So we have so much facilities in the anatomy dissection hall now. Of course, manicures, all those starts to come. So we should make use of these facilities to teach and train the students also. I think Dr. Balal and Dr. Eke have told very beautifully what all has to be done, what was happening. I don't want to repeat again that. I missed Ilango's talk, but I'm sure he has given the principles of how to teach and train the students. And lastly, I want to tell you that please involve other specialties also. Don't restrict to the general surgery alone. Make it as a principles of practice of surgery, training and practice of surgery, so that all specialties will be included. This is a beautiful forum which is taking place, and I'm sure Vidya and Radhakrishnan will have flying their flags in their curriculum. So I personally feel that think about these lines and involve others. Thank you very much, Vidya, for asking me.
Thank you, sir. We'd like to hear from another student, Dr. Mahila. Dr. Mahila Yasmin, please unmute yourself and if possible, turn your camera on.
Good evening, ma'am. Good evening, everyone.
Good evening. Welcome.
Thank you, ma'am. Yes, ma'am. Ma'am, I'm studying in a peripheral medical institute in Hyderabad. We have very few PGs here and volume is also less. So because of that, I took surgery by choice, ma'am. So, but because of my rank and so, I got in such a college. I was grateful for everything. But when I saw that there is so much to learn on a virtual platform, COVID was actually a blessing for me. A literal blessing. Because of that, I found out about LGS, and further on, I found out about Dr. Girija's classes. And then after that, when I prepare for each class, ma'am, I tend to think that I'm also at a level where I can also answer, because even though I'm so far away, I can still prepare, I can still answer. So sir has given me that confidence. And how we can improve, ma'am, from my side, I thought if we can have a structured teaching program for a month, ma'am, like on the beginning of the month, if we can know which classes are going to be taken, or maybe some idea about weekly programs, that will be good, ma'am. I can study in advance for that, or so and so, and we can plan so far, ma'am. And also ward rounds, ma'am. We have very few patients, so rounds are also not so much for us. But to be at par with everyone when we finish MS, from my side, I would suggest that if sirs can teach us from their side how to do post-op rounds, what to see, what to check in each patient, then that will be fine. That's much from my side, madam.
Thank you for your inputs, Maliha. Dr. G.V. Prakash, we'd like to hear from you, sir.
Thank you very much, and I'm really grateful to Professor Shana sir, Radhakrishnan sir, and my group, Dr. Vinay Kapoor sir, Anand Krishnan sir, and Nandi sir. Sir, excellent talk already dealt with. I don't want to take much time. My thought is to improve the importance of study of the involvement of the student done only by the examination should be conducted just like DNB examination. Like if the candidate doesn't know where is going to, which station is going to appear for the practical examination, he'll definitely prepare well, concentrated, and studies well. If in the same local station, he is guaranteed passing, like Professor Anand Krishnan has already said. So once it is conducted on par with national board examinations, I see the national board exam students perform better than the routine MS General Surgery students. They study better than, though their teaching facility is less compared to routine MS degree colleges. Their preparation is much better because they put up their personal time running to different places to learn the cases. So that's my suggestion, sir. Thank you very much for giving this opportunity to me. Thank you, sir. Thank you, madam.
Thank you, Dr. Prakash. Dr. Girijadar Sharma, sir, we have waited a long time to hear from you. The pillar of learning general surgery, like Radhakrishna said, and avid teacher. What would you like to see in this series?
Vijay, Dr. Purnendu wants to come for a minute before Professor GDS comes. Purnendu?
Okay. Just 1 minute. I wanted to pay my regards to Professor Kapoor. When laparoscopy first started in a national conference, I had presented all the complications which I had created, all the video, how I cut the bile duct, how I cut arteries, how injuries were happened. And Professor Kapoor came up to me, he might not remember, patted my back and said, this is what I want, even though there was severe protest that we should not show these things. This will bring disrepute to laparoscopy. And I had told, as Ilango was asking how to give skills, if many of us put up videos of the complications which we create, then there are much more to learn from watching other people's complication than to learn successful, because information is available everywhere. All of us can get information. Skill one has to practice, but how not to do surgery, that is also very important. So if different surgeons can create their videos of bile duct injuries or other, or duodenal blowout or anastomotically, then that will give some practical hints. And I wanted to pay my respect to Professor Kapoor, because he was the only one that time came and patted me and said that it shows a lot of courage to show your own complications, and all of them in front of such a huge audience. My regards to Professor Kapoor.
The only thing I would say that it may give kind of better feeling to your so-called competitors, but I'm sure you must have earned a lot of respect from the students.
So you might not remember, but I remember this. And every day I remember that how you came and told me that it just shows your courage, what a surgeon you are, to show all the complications in video, what you have created. Thank you, sir.
Dr. GTS, sir. Yes.
Good evening, everybody.
Good evening,
The teachers of teachers, and it's a real pleasure to have on LGS, and I welcome all of you on behalf of LGS on this platform. A lot of good things have been said. You see, we can mend few things at our level. We cannot change the policies, but nobody can stop us from motivating both parties, the young teachers as well as the residents. I have specialized all my life in helping the failed candidates. Since I left CMC, I always created a post where I got people who have failed once or twice. They would come work 6 months or a year with me. Always treated these young residents as my own kids, as Professor Kapoor sir said so. And an important point to share is on LGS platform, we ran a program of fellowship on art of communication for young surgeons for a year before COVID. Chennai, Hyderabad, and Bangalore. And there was dedicated time spent on them every day on art of communication, on art of conduct, how to dress, and I even taught them how to drink. You should not be known as a drunkard in society, right? So all these things, in eventually, when you face public, every small thing matters. Communication being the most important. So as soon as the COVID gets down, I'm willing to start the similar program again. And it will be worth if some programs like this are started elsewhere also in the country. The candidates whom I attract are usually, I have with humility to accept, I train only the lower third candidates on merit. And believe me, once push them to the wall, all of them are performing exceptionally well. And everybody is getting into a good, though they were lower third residents to start general surgery training, by the time they finish general surgery, most of them are getting into high merit for super specialty trainings. So commitment on the part of teacher, motivation, and leading by example can surely motivate even the unmotivated. That's all what I would say. We are all willing to improve on this platform to help the. Thank you.
Thank you, sir. We were looking at not so senior teachers' viewpoints as well. Balamurugan, we'd like to hear from you. Bala, can you unmute yourself?
Yeah. Yeah, I've been following what has been happening today, and it is always a pleasure to get to see Chief Ananth Krishnan, sir. My pranams once again, sir. Yeah, taking it forward, it is also a good opportunity not only to develop surgical skills, but also expose them to the varied super specialities so that they can also see whether they have a liking or an inclination towards the super specialities. Of course, the principles are the same. Whatever has been told for incorporating in surgery are applicable in the super specialties as well. And what they inculcate during the surgical training goes a long way in fine-tuning their skills in the super specialty course which they want to pursue and in their life thereafter. See, I have had the fortune of doing MS in JIPMER and MCH in AIMS, but I can proudly say the training was much more organized, and whatever I am today, whatever principles I have acquired, it is all because of the organized training we had in JIPMER under Professor Ananth Krishnan. So we can use this as an platform to expose the surgical graduates to the options available so that they can see whether they have the aptitude and inclination towards the super specialties. That's also one thing which we can do here.
Thanks, Bala. We have Dr. Geetanjali, who literally started an institution from scratch. So Geetanjali, your thoughts on what do you think needs to be done differently for surgical training?
Thank you, Vidya. I mean, I am really very happy to know that something like this is starting. See, because I can tell you that in the last few years, I have been doing a lot of recruitment. Both, people who have just finished MS who are appearing for senior residency, also people who have completed senior residency who are appearing for assistant professor or associate professor posts and things like that. And I can tell you the standard is appalling. The standard is very, very poor, no matter from which background they are coming in. So this is something which is very much needed. Actually, I loved Ilango's talk, but I can tell you that the point is now we are not able to get these people to read. In a place like AIMS, we spend almost 4 crores per year on our library, but we are seeing that students as well as faculty are not reading the journals which we are subscribing to. And similarly, in a place like Jipmer, where when I did my internship, of course, it is many decades ago, but we were taught how to do dressings by, the faculty. But if you take a place even like AIMS, we are not able to get the surgeons to come, even do post-op rounds, come in the night or during a weekend or a public holiday. We are not able to get faculty to come. So when will they teach these people, the residents? That's the whole problem. See, when we were interns, or I have seen myself, some residents were taught by faculty who used to come on weekends, come after office hours and teach. And that's something which is going on in some of the very well-established, AIMS Delhi and many of the established colleges, but that's not happening in the new colleges at all. So it's very sad that we have to do something like this, but so I appreciate your enthusiasm and this initiative. This is very much needed, because I can tell you one thing, the standard is very poor. And one of the things why the standard is poor is because we are giving excuses for passing people. And I can tell you, because just recently we had a recruitment for assistant professors, and one of the experts in surgery was going on asking, you classify surgical wounds. And can you believe that somebody who's coming to appear for an assistant professor interview cannot even classify surgical wounds? And it's not just 1 or 2 people, but it was a whole lot. About 80% didn't know. So that's the whole problem. I mean, leave alone skills, trying to teach them skills, but now you are looking at pure knowledge. So I really don't know. And so this is an initiative which is very much needed. And I really, I am very appreciative of this. Thank you, Vidya.
Thanks, Geetanjali. Dr. Neeta, would you like to say something? Maybe a couple of minutes. Would you like to say something? You had posted some points on the chat. Right. If anyone else would like to say something, I might have missed somebody. Please feel free to put your hand up or unmute yourself and speak. We'll be winding up in the next few minutes.
Dr. Prabhakar, you want to speak? He's head of the Department of Surgery from Tumkur. Dr. Prabhakar.
Welcome, Dr. Prabhakar.
Yeah, good evening. Actually, it's a good program. What I am hearing to all my seniors and teachers, especially my pranams to C.R. Ballard, was a very good teacher for us during our postgraduate this thing. Actually, we are missing a lot of such teachers present days, probably because the teaching, usually they used to opt for as a passion. Now, the younger generation they're just joining medical colleges to set up their practice or other things. So they are not concentrating towards teaching. I'm getting really difficult, even with our junior doctors, to withhold in the department itself. Most of them, they'll just sign and they'll just go off. So they don't bother to teach the thing. So that attitude, actually, we have to change for the teachers. It is actually, our C.R. Ballard sir said, we have to train the trainers. So that is more important than we should not blame the students. I think
it is major failure is in the teachers itself. So we have to correct those things. I think, thank you for giving this opportunity to put forth my ideas. Thank you.
Dr. Raghavendra Prasad, would you like to say something? Dr. Raghavendra Prasad.
Hello.
Yes,
are you
sir.
hearing me, madam?
Yes, please.
Yeah.
Loud and clear.
I am Raghavendra Prasad from Hyderabad. I've been a teacher from 1979 till today. I have realized that my colleague teachers are not keeping updated, and therefore we do not have now as teachers any control of what type of student comes to us. Most often we don't have a control who is going to pass. What is left to us is from day one, be very strict in training both science and the art. The science is forgotten by teachers. Most of the teachers are not updated with the current basis of science, and therefore they cannot make the topic interested. As that girl was telling, they should know if they present a grand round case, suppose a post-op case of thyroid having a pharyngeal fistula, they should tell anatomy of that, what could have gone wrong, then the principles of management of such type of rare pharyngeal fistula. And so is anastomosis well done on table, documented well. He has anastomotic leak. How to go about it? The science behind what was done, what could have been done better, what was missed as a part of surgical basis. Next is, we are not strict at all. If you say 100 teachers, hardly one teacher is strict. All others are happy-go-lucky. If they come or not come, they are not bothered. Although the powers are with them, powers are not with the administration, even in private colleges. If they are strict, at least 50% of students can be better to become a better surgeons. Therefore, these two aspects, the science and art, we have not concentrated on art at all. It was only a skill based. My teachers supported skill, but they never told the art behind. None of us have taught what an incision is. We make incisions, but we never know what is exactly the definition of incision is. Incision is a surgically made wound to access the point of interest based on sound scientific principles of anatomy and physiology of wound healing, artistically designed, executed with engineering precision. So many components of incision are not taught to us. Therefore, I think we need to change first. Then we can think of the changing the student who can be a future teacher or future surgeon. Thank you very much.
Thank you so much, sir. Ilango, for your closing comments, please.
I was taking notes of all the things that were being discussed. Thank you for all the new ideas. This is a new experiment for us. We would like to bleed in new ideas from both the established and well-recognized teachers of our country, as well as from the young breed of surgeons who are interested in teaching and imparting their skills to other people. I've taken your ideas from Professor Shinoy, from Professor Rajaram, Professor GDS, and I've also taken Dr. Mahila's notes as well, and and I have drawn up some ideas, and I think I will draw up the topics over this next year based on what we have been discussing and what would be discussed in the next few forums, and then we will bring about new ideas and change. Thank you very much for being with us and being a part of this program. And your blessings are needed to keep the program going on as well. Thank you everyone who participated in this on behalf of Learning General Surgery. Thank you.
Ilango, would you like to tell them what's coming up next week?
So there will be a discussion on anatomy. The module is run by Professor Balasubramaniam, who teaches anatomy, who's interested in virtual reality. And he's going to discuss on how anatomy was learned as a student by him about 45 years ago, and then how he taught anatomy as a young teacher and how he's teaching anatomy now. So this will be a two-part program on the teaching skills in anatomy. We'll come up with the final topic, the actual title of the topic in a short while, and we'll announce it on LGS, but it will be on anatomy teaching. So we thought we'll take up anatomy this time because it's something we introduced as a student, and some of the surgeons, as surgeons, we learn anatomy even to the end of our lives. So I think that's a good point to start with. Thank you, ma'am.
Thank you.
Good night, thank you, Dr. Vidya, Madam, and Ilango. I did not thank you during my. Thank you very much, everyone. Dr. Kapoor, sir. Thank you very much, sir.
Thank you very much, Kapoor, sir.
Thanks,
Vinay,
sir.
sir. Thank you, Vinay, sir.
Everyone, thank you, sir.
Thank you, everyone, for joining, and we will be reaching out to you to do some of the programs, and please keep the your thoughts and ideas flowing, and the LGS page is always there, or you could either WhatsApp or email Radhakrishna, Ilango, Sethu, or me for any ideas that come up. Thank you so much for sparing your time. Please take care and stay safe. Good night, and we'll meet you again next Tuesday with the first official episode of Learning Surgery. Thank you.
Nice to hear you, Dr. Raghavendra Prasad, sir. Nice to hear you.
Thank you very much. Thank you.
Right. Good night, sir. Good night.